Respiratory Physiology, Understanding Hypoxemia and Hypoxia. Welcome to today's podcast, where we're delving into two fundamental concepts in respiratory physiology, hypoxemia and hypoxia. These terms are not only essential for clinicians, but understanding them provides insight into how the body responds when oxygen delivery is compromised. Let us begin by clarifying the definitions. Hypoxemia refers specifically to a reduced level of oxygen in the arterial blood. It is measured by a decreased partial pressure of oxygen or a lower percentage of oxygen saturation in the arteries. In contrast, hypoxia is a broader term that encompasses any situation in which tissues do not receive enough oxygen to function properly. Hypoxemia frequently leads to hypoxia, but hypoxia can also occur even when blood oxygen levels appear normal. In essence, hypoxemia is a challenge rooted in the blood, whereas hypoxia concerns the cells themselves. Now, let us explore the 5 primary causes of hypoxemia, each with its own distinct mechanism and clinical implications. First, we have the scenario of low inspired oxygen pressure. This means that the oxygen entering the lungs is already insufficient. It typically occurs in environments such as high altitudes, where the thin air contains less oxygen, or in cases of suffocation and exposure to gas mixtures with reduced oxygen content. In these circumstances, both the oxygen in the alveoli and in the arterial blood decrease proportionally. Second is hypoventilation. This mechanism involves reduced air movement in and out of the lungs. When ventilation is insufficient, carbon dioxide builds up within the alveoli, in turn lowering the available oxygen. This can happen due to drug overdoses that suppress the brain's drive to breathe, neuromuscular diseases that weaken breathing muscles, or structural chest abnormalities. Here, the reduction in oxygen affects the lungs and the blood equally. The third mechanism is diffusion limitation. In this case, the membrane across which oxygen passes from the lungs to the blood is thickened or damaged. While this may not always cause noticeable symptoms at rest, it can become significant during exercise, when oxygen must cross the membrane more rapidly to meet the body's increased demands. Conditions such as pulmonary fibrosis and fluid accumulation in the lungs are common causes. Our fourth cause is ventilation-perfusion mismatch, which is the most frequent reason for hypoxemia. In the healthy lung, ventilation, the movement of air, and perfusion, the flow of blood, are closely matched. Disease can disrupt this balance, leaving some lung regions well perfused but poorly ventilated, and others the reverse. When blood from poorly ventilated zones mixes with blood from healthy parts, the overall oxygen content drops. Examples include chronic obstructive pulmonary disease, asthma, pneumonia, and collapse of lung tissue. Notably, this type of hypoxemia often responds dramatically to supplemental oxygen. Finally, there is the right-to-left shunt. This is an extreme form of ventilation-perfusion mismatch in which blood passes from the right side of the heart to the left side without receiving any oxygen from the lungs. Shunts may be anatomical, as seen in congenital heart defects, or physiological, as in severe lung disease where whole regions of the lung are bypassed. One key feature is that providing extra oxygen has little effect, since the shunted blood never reaches ventilated lung areas. Moving forward, let's discuss the broader concept of hypoxia, which can be classified into several types depending on the underlying cause of inadequate oxygen delivery to tissues. The first type is hypoxemic hypoxia, which directly results from low oxygen levels in the arterial blood. All previously discussed causes of hypoxemia fall under this category. Next is anemic hypoxia. Here, although the partial pressure of oxygen in the arteries is normal, the blood's capacity to carry oxygen is reduced because of a decrease in hemoglobin or dysfunction in the hemoglobin molecule. This can occur with significant blood loss, iron deficiency, or carbon monoxide poisoning, wherein carbon monoxide binds to hemoglobin with far greater affinity than oxygen does. Circulatory or stagnant hypoxia arises when blood flow to tissues is insufficient, even though the oxygen content of the blood is adequate. This situation can develop in cases of heart failure, shock, constricted blood vessels, or arterial obstructions. Because blood moves slowly, tissues extract more oxygen from each unit, leading to a pronounced drop in oxygen in the returning venous blood. Lastly, we have histotoxic hypoxia. In this scenario, the cells are unable to utilize the oxygen delivered to them, typically due to toxins that interfere with cellular respiration. Cyanide poisoning is a classic example, as it inhibits enzymes necessary for cells to extract energy from oxygen. Interestingly, In histotoxic hypoxia, oxygen remains high in the venous blood because the tissues cannot use it. Recognizing hypoxemia and hypoxia clinically is critical. Signs may include bluish discoloration of the skin and mucous membranes, rapid heartbeat, increased breathing rate, confusion, and restlessness. The body responds with a range of compensatory mechanisms. It increases ventilation, boosts cardiac output through a faster heart rate, produces more red blood cells over time through the action of erythropoietin, and directs more blood flow to oxygen-deprived regions by dilating blood vessels. To summarize, understanding the difference between hypoxemia and hypoxia, as well as the mechanisms behind them, is essential for accurate diagnosis and effective intervention. For example, administering high concentrations of oxygen can fully correct hypoxemia due to ventilation-perfusion mismatch but will have little effect in cases of histotoxic hypoxia or significant right-to-left shunt. Thank you for joining this discussion. Stay tuned for our next episode as we continue to explore vital topics in human physiology and medicine. It's the Everything Surgery Podcast. Dissect the Extraordinary.